Okay, let's unpack this.
Let's do it.
Today, we are taking what is, I think, arguably one of the most fundamental chapters in all of surgical practice. We're doing a deep dive into Chapter 35 of the 28th edition of Baily and Love's textbook.
The bedrock.
Exactly.
Yeah.
It's the absolute bedrock. Taking a history and performing a clinical examination in musculoskeletal or MSK disease.
And, it's important to frame what we're doing here. Our mission today is really tailored for you, the learner.
Right.
This is not just a recitation of the textbook. Our goal is to interpret the structure, provide some really critical cognitive anchors.
Things that make it stick.
Exactly, to create a sort of high-yield reckoner for revision and for, conceptual clarity. This deep dive should be seen as the scaffolding.
Right. It enhances, but it absolutely does not replace reading the source material itself.
Absolutely not. You need the detail in the book.
And when we talk about the musculoskeletal system, it is a tremendously complex architecture. We're talking bones, joints, ligaments, muscles, tendons.
And crucially, the associated neurological and vascular systems that supply them. You can't separate them.
No, you can't. And the sheer volume of potential pathology means you have to have a rigorous, systematic method of assessment.
If you don't have that system, you will miss something. It's almost guaranteed.
It's fascinating, really, the systematic discipline that orthopedics demands.
It really is. The stakes can be incredibly high. You're diagnosing common problems, yes, but also rare ones and sometimes critically urgent problems.
And you have to do it reliably.
To do it reliably, you need a reproducible method, a non-negotiable checklist that you can apply to every single joint.
Which brings us to Apley's.
It brings us to Apley's classic approach, which we're going to call the orthopedic trinity.
I like that.
Look, feel, and move. That structure is your guiding light. It ensures a complete and an objective assessment every single time.
Okay, so let's start at the beginning. Before we even get to Apley's Trinity, we have to start with the professional gateway.
The history.
The history. And the first steps in the book are focused entirely on professional conduct and really patient safety. We're talking hand hygiene, a proper introduction, verifying the patient's identity, getting that explicit verbal consent.
And critically, ensuring the presence of a chaperone when it's appropriate, especially, when discussing sensitive areas or requiring full exposure.
Setting that professional tone just dictates the quality of the entire assessment, doesn't it?
It really does. If the patient doesn't trust you or if the environment feels rushed, the history you get will be deficient. It all starts by just giving the patient the floor.
Right. And we start with that classic open-ended question that frames the whole encounter. Explain what the problem is in your own words.
Which is so important. It helps you understand their main complaint, the chronology, and just as important, it starts to establish their expectations.
Yeah, what are they hoping for? Are they expecting a quick fix, a referral for surgery, or maybe just reassurance?
Understanding their perspective from the get-go manages the whole consultation.
From there, we immediately transition to structuring the history of the presenting complaint.
And we anchor this with what we're calling the fundamental 3 Ws.
Okay.
When did the problems start? What were you doing at the onset? And was the onset sudden or gradual?
And that last W is such a powerful diagnostic tool.
It's huge. Sudden onset, it often points to acute trauma, a fracture, maybe a joint dislocation.
Whereas gradual onset.
Gradual onset strongly suggests more insidious processes like chronic degeneration, a slow-moving infection, or inflammation.
So once we have that crucial timeline established, we broaden out the inquiry to the symptom profile. We're moving beyond just logging the location and the severity of the pain.
Right. These associated symptoms are the clinical signposts, and they point you to the pathological structure. We need specifics.
So what are you asking for?
We have to actively ask about swelling. Is it an effusion inside the joint capsule, or is it localized soft tissue edema? We ask about instability, which patients often describe as the joint giving way or just feeling unreliable.
And then there are the mechanical symptoms.
Yes, and these are vital for diagnosing what we call internal joint derangement.
Tell us a bit more about those. Why are things like locking, clicking, or clunking so specific?
Well, clinically, they are just gold dust because they often localize the pathology to inside the joint, the intra-articular space.
So a click might just be a capsule snapping over bone.
It might be. But true locking, where the joint becomes momentarily fixed, that suggests something is physically catching inside.
Like a torn meniscus.
Exactly. A displaced meniscal tear or maybe a loose body, sometimes called a joint mouse, that's just obstructing the smooth motion of the joint.
This then leads perfectly to what you call the so what question, functional impairment.
Right.
This is the crucial bridge between defining a symptom and understanding the patient's actual quality of life.
Correct. And this information is key because it defines the surgical indication and it gives you the outcome measure after your intervention.
So for the upper limb, we're focusing on fine motor tasks.
Yeah, things like personal hygiene showering, dressing, feeding, fastening buttons, or grasping small objects. Can they turn a key in a lock?
And for the lower limb, the anchor tasks are more about basic mobility.
Absolutely. Putting on shoes and socks, standing for a long time, walking, and the ability to climb or descend stairs.
And if a patient can't manage stairs, their need for intervention often becomes significantly more urgent.
Especially depending on their accommodation type, that's a huge factor.
So after we've documented the current problem thoroughly, we sweep through the systemic context, past medical history, past surgical history.
And this is not just a formality.
Not at all. Comorbidities like severe diabetes, uncontrolled hypertension, or chronic respiratory conditions like COPD or asthma profoundly affect their fitness for anesthesia and their post-op recovery.
And you have to ask about previous anesthesia issues. You must know if a relative had malignant hyperthermia, for instance.
Right. And if we connect this to the bigger picture of surgical risk, the drug history check becomes, well, arguably one of the most high-risk parts of the entire assessment.
I'd agree with that. Even more so than some parts of the physical exam, we have to focus intensely on medications that act as surgical contraindications or severe risk factors.
Okay, so let's break down that critical list of red flag medications. And crucially, why they are red flags.
Certainly. First up, anticoagulants like warfarin or the newer DOACs and antiplatelet agents like aspirin.
And the reason is pretty immediate.
It's immediate surgical risk. They exponentially increase the risk of bleeding during surgery and hematoma formation after, which can cause wound breakdown or even compartment syndrome.
Okay, second category.
Immunosuppressant therapy and, critically, steroids. Steroids are red flags on multiple levels.
How so?
While they impair wound healing, they increase the risk of surgical site infection, and if the patient has been on long-term systemic steroids, they risk acute adrenal insufficiency during the stress of surgery.
Which is a life-threatening risk.
A huge life-threatening risk.
Okay, and the third category.
We have to specifically ask about the oral contraceptive pill, OCP, and hormone replacement therapy, HRT.
Now, these don't affect wound healing.
No, but they establish a higher baseline risk for venous thromboembolism, or VTE.
Deep vein thrombosis, pulmonary embolism.
Exactly, and when you combine that elevated baseline risk with the immobilization that's required after surgery, the VTE risk profile just increases exponentially. Knowing this upfront dictates your entire perioperative thromboprophylaxis plan.
That really highlights why knowing the mechanism of these drugs is so critical. Which brings us to our first check-in question.
Okay.
Before we move on to the physical exam, think about this and rewind if you need to. Why is asking about the use of steroids so much more critical in a surgical history than, say, a common allergy like hay fever?
It's a great question, and the answer is really about systemic survival and recovery.
Right.
A hay fever allergy might require medication change, maybe, but steroid use fundamentally compromises the patient's ability to mount an effective stress response and to heal the surgical wound. It's a fundamental assessment of operative risk.
And it might mean you have to give them supplemental steroids.
It might mandate it, yes, and that's a critical decision that only comes from careful history taking.
This leads perfectly to a quick case study to illustrate this very point. Let's call it Case Study 1, the Weekend Warrior.
Okay.
A 55-year-old cyclist presents with chronic knee pain. It's possibly an arthroscopy for a meniscal tear. You discover in his past medical history that he is on immunosuppressants for a distant autoimmune condition, say Crohn's disease.
Right. So the mechanical problem in the knee might be simple, but the systemic risk transforms the entire case.
How so?
Well, that immunosuppressant therapy raises serious flags. Even a minimally invasive arthroscopy carries a risk, and for this patient, the risk of septic arthritis or poor graft integration is magnified.
So it's not a straightforward case anymore.
Not at all. It requires multidisciplinary input. You need to talk to his rheumatologist or gastroenterologist. You probably need to temporarily wean or alter his medication regimen. It completely alters the timing and the risk-benefit analysis of what seemed like a simple elective procedure.
You realize the patient is taking drugs that actively make healing harder.
Exactly.
And finally, we gather the social history, but we tailor the questions directly to the MSK consequences.
Right. Hand dominance is crucial for rehab plans. Employment status dictates the urgency of their return to function.
You're asking about walking aids, accommodation type.
Do they live in a third-floor flat with no lift? Do they have a support system? This contextual information ensures the treatment plan is actually viable once the patient leaves the hospital.
The history really is a funnel.
It is. You start broad with that open question and the patient's expectations. You narrow down quickly with the 3 Ws and the mechanical symptoms.
And then, and this is the key, you broaden out again to capture all the systemic risk factors and the social context that influence both the diagnosis and the patient's ability to recover.
That systematic sweep is what ensures nothing high-risk or life-altering is missed.
Okay, let's move on to the objective assessment, the physical examination. We're shifting our focus entirely to that orthopedic trinity.
Look, feel, and move. And Apley's is not just a suggestion, it is a mandatory systematic discipline.
You have to know why you're doing each part.
You have to, and you must adhere to the rule of comparison. Always, always compare the affected side to the unaffected side, and the painful joint to the one above and below it.
Let's start with look, or inspection. The source material is very clear. Inspection begins the instant you walk into the room.
Yes. What are the key non-joint observations you're looking for? You're assessing the patient's general appearance, their posture, their use of walking aids.
But crucially, you look at the whole patient, not just the painful joint.
You have to, because systemic diseases often declare themselves distally. For example, looking at the hands might reveal ulnar drift or Heberden's nodes, which could be the systemic cause of their painful knee.
Or if they present with shoulder pain.
Checking their pupils might reveal Horner syndrome, hinting at a Pancoast tumor in the lung apex affecting the brachial plexus. It's about connecting the systems.
And for the focused inspection, we need that non-negotiable exposure. The joint above, the joint below, and the opposite limb for comparison.
Always.
What are the specific red flags we're looking for on the skin?
We need to look very closely at the integrity of the soft tissues. Scars, our vital arthroscopy scars, can be incredibly subtle, but they suggest prior surgery which dictates future management.
Bruising.
Bruising might suggest recent trauma, sure, but recurrent or disproportionate bruising could hint at a bleeding or clotting disorder.
Eryema. Redness. Warmth.
That signals inflammation or acute infection, cellulitis. Ulcers are critical. They point toward underlying vascular compromise, poor sensation, or chronic pressure, and the presence of sinuses.
That narrow tract leading to a deeper structure.
That is the classical sign of chronic osteomyelitis or a deep infection.
And if we focus inward on the soft tissues, what about size and shape?
Swelling is key. Is it a bony enlargement, like an osteophyte, or is it a soft, fluid-filled effusion? And we look intensely for muscle wasting.
Which could be simple disuse from avoiding pain.
It could be. But it could also signal a serious underlying neuropathy or a lower motor neuron pathology. If you see fasciculation, those small involuntary muscle twitches, that strongly suggests LMN disease, and you need to refer them for neurological investigation urgently.
Now, before we even touch the patient, we have to decode the gait cycle assessment.
Yes.
I quite like the analogy of the 100-meter relay race.
It works perfectly. The gait cycle is the period from the initial contact of the foot with the ground to the subsequent initial contact of the same limb.
And it's divided into 2 main phases.
The stance phase, which is about 60% of the cycle, when the foot is grounded and bearing weight, and the swing phase, about 40% when the foot is moving forward.
You have to watch them walk toward you, away from you, and turn.
You have to, observing for any spontaneous deviations.
So let's elaborate on the key pathological limbs from the source material. The first one is the antalgic limb.
This is the most common. It is driven purely by pain. The clinical significance is the short stance phase. The patient unloads the painful limb as quickly as possible,
creating that characteristic dot-dash rhythm.
Exactly. This type of limp often suggests acute mechanical instability or severe inflammation.
Then there is the stability issue, the Trendelenburg limp.
This signifies weakness of the hip abductors, the gluteus medius and minimus on the stance leg.
Right.
And the mechanical consequence is that the pelvis drops on the unsupported side, the side that is swinging.
And to prevent falling, they compensate.
They shift their torso over the weak hip to stabilize their center of gravity, which creates that classic windscreen wiper or exaggerated lateral sway. That sway is a compensation they've instinctively developed.
And other gaits include the high-stepping gait,
Suggesting foot drop, maybe from a common peroneal nerve palsy,
and the incoordinated or ataxic gait.
which points you straight toward central nervous system pathology, like cerebellar dysfunction.
Moving now to feel, or palpation.
Yeah.
This requires gentleness and a systematic approach.
And the cardinal rule is to palpate the normal asymptomatic side first, especially with children or anxious patients.
To set a baseline.
To set a baseline, understand what normal feels like, and build that necessary rapport.
When you're palpating for tenderness, you have to determine the anatomical structure. Is it muscle, tendon, ligament, bursa, or bone?
And we use a systematic checklist for lumps or effusions, the SWILLING acronym.
Let's run through that.
Start onset, where site, internal features, consistency, mobility, lymph, nodal status, liquid, transillumination, external features, color, size, and general systemic symptoms. It guarantees a thorough assessment.
And let's talk about the absolute rule regarding vascular status checking distal pulses.
This is a non-negotiable safety check. You have to document the presence and quality of distal pulses. If a pulse is absent due to trauma, it's a surgical emergency.
And even in elective surgery.
The absence of pulses or evidence of severe peripheral vascular disease is an absolute contraindication to an elective procedure in that limb. The tissue just may not survive the operation.
Finally, we arrive at MOVE, the assessment of the range of motion.
We define and measure the range of movements: flexion, extension, abduction, adduction, rotation, and we record them in degrees.
But the key diagnostic insight here is the relationship between active and passive range.
Right. Active movement is what the patient can do themselves. Passive movement is the range you can achieve when you move the joint for them.
So let's reemphasize that diagnostic distinction. If active movement equals passive movement, but both are painful or limited,
That is pathology within the joint itself. A global mechanical issue. Think of severe arthritis or a capsulitis. The stiffness limits everything.
but if the passive range is significantly greater than the active range,
That tells you the joint is mechanically free to move, but the motor mechanism, the muscle, the tendon, or the nerve, is failing. That points toward muscle weakness, tendon rupture, or a neurological palsy.
and we assess the function of those motor units using the MRC grading system for muscle power, 0 to 5.
Yes, and grade 3 is the critical point to anchor in your memory.
Why grade 3?
Grade 3 is the point where the patient can achieve active movement against gravity alone. If they can overcome gravity, they are at least a grade 3. Grades 4 and 5 are about movement against increasing external resistance.
Okay, now for another check-in question to make sure we've absorbed the nuance of the MOVE phase.
Go for it.
If a patient can actively abduct their arm fully to 180 degrees, but they experience extreme pain only between 60 and 120 degrees, what anatomical structure is likely the culprit, and why is that specific range so important?
We are squarely in the move phase, and the presence of pain specifically within that intermediate arc is highly suggestive of impingement syndrome. It's the classic painful arc test.
And anatomically, what's happening there?
The pain occurs because in that specific arc of movement, the supraspinatus tendon, the most commonly affected rotator cuff tendon, is being physically compressed or pinched as it passes beneath the bony arch of the acromion.
And then when they move beyond 120 degrees.
The tendon slips out of that compressed zone and the pain often subsides. It's pathology tied to a specific mechanical passage, not the whole movement.
So, key takeaway 2 on the general exam. Apley's look, feel, move is your map.
But the single most powerful diagnostic insight comes from comparing the active versus passive range of motion. That relationship tells you if the problem is mechanical joint stiffness or motor failure. And remember, grade 3 power confirms movement against gravity.
Moving from the general rules to a specific region, let's start with the spinal column, the foundational support of the MSK system.
33 vertebrae, 23 discs. It's an exercise in structural mechanics and neurology.
Our primary anchor for alignment is the plumb line metaphor.
Right, for the coronal plane. You drop a line from the spinous process of C7, and it should fall straight through the midline of the gluteal crease. Any deviation laterally suggests a tilt.
We also assess the sagittal curves, the natural balance. We need cervical and lumbar lordosis and thoracic and sacrokyphosis,
And a critical clinical sign is the loss of normal lumbar lordosis.
which you see a lot in acute low back pain.
All the time. The deep paraspinal muscles go into a painful spasm, acting like a protective splint. The spine flattens out, trying to immobilize the affected segment.
Let's focus first on the cervical spine. C5 to T1 nerve roots supply the entire upper extremity.
We look for alignment, then we systematically assess and measure movement. Flexion, extension, rotation, and lateral bending. This quantification is essential for tracking things like spondylosis.
And the high-yield special test for nerve compression in the neck.
That is Sperling's test. The mechanism is purely mechanical compression.
So what are you doing?
The examiner turns the patient's head to the affected side, extends the neck slightly, and then applies gentle downward pressure. This physically narrows the intervertebral foramen.
A positive test is the reproduction of that radiating pain down the arm.
Exactly, indicating active nerve root entrapment. But you have to use great caution with this maneuver.
Moving down to the thoracic spine, we often look for deformity, particularly scoliosis.
An inspection must include looking for subtle skin markings, sometimes called stigmata.
Like hairy patches or cafe au lait spots.
Yes, they can signal underlying occult pathology, like spina bifida, that may be driving the spinal deformity. The key test is the forward bending test, or Adams test.
And this test gives you the diagnostic difference between the two main types of scoliosis.
It does. When the patient bends forward, you look for a rib hump. If it's structural scoliosis, the fixed rotatory deformity means the rib hump will increase in size. It's fixed.
But if it's functional scoliosis,
Secondary to something like a leg length discrepancy, the spine straightens entirely when bending forward, the rib hump disappears, the deformity is flexible.
now the lumbar spine. The book emphasizes a crucial point. The lumbar exam is incomplete unless it includes the hips, lower limbs, and gait.
Because irritation of the nerve roots here so often mimics lower limb problems. That's classic referred or radicular pain.
Palpation of the spinous process is essential, especially feeling for a step off.
That's the sensation where one spinous process sits forward relative to the one below it. It strongly suggests a forward slippage of the vertebra, which we call spondylolisthesis.
We also need to assess movement accurately, knowing that forward flexion involves a big contribution from the hips.
So to isolate true lumbar flexibility, we use the skin stretch test. The examiner places reference marks over T12L1 and the lumbosacral junction. When the patient bends forward, you measure how far those 2 points separate. It gives you an objective measure of the lumbar spine's flexibility, independent of the hips.
Okay, now for the most famous lumbar special test, the ultimate anchor for sciatic pain. Lassig's test or the straight leg raise?
This is the definitive nerve root tension test for the sciatic nerve, the L5 and S1 roots. It is a carefully orchestrated test.
Walk us through it.
The patient is lying supine. The examiner raises the leg passively, keeping the knee in full extension. If pain occurs, we note the degree. Then we release the tension slightly and firmly dorsiflex the ankle.
And if that final dorsiflexion step reproduces the pain running down the leg?
That is a positive test. Highly specific for nerve root irritation, typically from a disc prolapse.
But the test that truly alarms us is the contralateral stretch test.
This one is highly specific for a significant lesion. If you elevate the asymptomatic leg, and this maneuver reproduces pain in the affected leg.
What does that mean?
That transmission of tension across the central structures confirms a centrally placed, space-occupying disc prolapse. It is a terrifying finding for us because it suggests a large central disc that demands neurosurgical vigilance.
Let's quickly anchor the key neurological findings for high-yield revision.
Okay, starting superiorly. C5 controls the deltoid, tested by the biceps reflex, sensation to the lateral upper arm.
C7.
C7 powers the triceps, controls middle finger sensation, tested by the triceps reflex.
And in the lower limb?
L4 innervates tibialis anterior, assessed by the knee jerk, sensation over the medial leg. And S1 supplies gastrocnemius, assessed by the Achilles reflex, sensation to the lateral and plantar foot. That table of 4 gives you the quickest diagnostic screen.
Time for our second case study to synthesize this spinal tension concept. Let's call it case study 2, the firefighter.
Okay.
A 40-year-old firefighter presents with severe low back pain radiating down his left leg. When you perform the straight leg raise on his right, unaffected leg, he screams about pain radiating down his left leg.
So the contralateral stretch test is positive. The critical implication here is that the tension applied to the right sciatic nerve is causing mechanical movement of a lesion, likely a large central disc prolapse, that is irritating the contralateral, the left nerve root.
And that's a serious finding.
A very serious finding. It often requires urgent imaging and sometimes surgical intervention because central lesions carry the highest risk of acute cauda equina syndrome.
So key takeaway 3 for the spine. The spine exam systematically connects posture, mobility, and neurology.
And Sperling's for the neck and Lassig's, or the contralateral stretch for the back, are your critical nerve tension tests. A positive contralateral test suggests a large centralized lesion.
All right, let's move on to the upper limb, specifically the hand and elbow.
The hand is, it's arguably the most complex functional unit in the body. It combines this exquisite sensory input with fine motor control. The exam here has to be absolutely detail-oriented.
And inspection alone can reveal advanced neurological lesions instantly, just from the resting posture.
Absolutely, that resting posture is crucial. An ulnar nerve lesion, for instance, will immediately present with a visible clawing of the little and ring fingers because of the muscle imbalance.
We anchor our inspection on key findings on the skin and bone that point towards systemic disease.
Right. On the skin, we're looking for tight, thickened bands in the palm, suggestive of Dupuytren's contracture. We also check for less obvious signs like a loss of sweating and hydrosis, which is a classic sign of complex regional pain syndrome.
And for bony deformities, we use specific names tied to specific types of arthritis.
For osteoarthritis, we're anchoring that with hard, bony swelling, Heberden's nodes at the DIP joint and Bouchard's nodes at the PIP joint.
And rheumatoid arthritis is different.
Rheumatoid arthritis, by contrast, gives us inflammatory instability and deformity. The classic boutonniere and swan neck deformities, plus the ulnar grift, where the fingers deviate laterally. These are all visual cues of long-standing joint destruction.
Now, the assessment of sensation requires real precision. Simple light touch is a good screen, but for a true deep dive.
You rely on the gold standard for fine sensory loss, which is the two-point discrimination test.
How does that work?
Using a calibrated tool, you determine the minimum distance at which the patient recognizes two separate points. A normal threshold is very small, maybe 5-6 millimeters in the fingertips. Loss of this ability is highly predictive of severe nerve compression or injury.
And we map this sensory loss meticulously to the three major nerves.
We check the median nerve distribution on the radial side of the index finger, the ulnar nerve on the ulnar side of the little finger, and the radial nerve on the back of the hand and the anatomical snuff box.
Before any procedure involving the hand or wrist, a vascular check is critical. This means performing the Allen's test.
This test assesses the adequacy of the hand's arterial blood supply. It ensures that the hand can be perfused by, say, the ulnar artery if the radial artery is temporarily compromised.
And the technique is 3 steps.
Occlude both the radial and ulnar arteries at the wrist. Have the patient make a fist until the hand goes pale, then release one artery. You then observe the time it takes for the color to return. A return within 2 seconds confirms an adequate supply from the remaining artery.
The hand is highly susceptible to compressive neuropathies, which we screen for using the classic T's and P's.
The T's and P's. So Tennell's test involves light tapping directly over the nerve, commonly the median nerve at the wrist. A positive sign is the reproduction of shooting pain or tingling into the nerve's distribution.
And Phelan's.
Phelan's test is a direct compression test for carpal tunnel syndrome. The patient maintains maximum wrist flexion for 1 minute. Reproduction of that median nerve paresthesia confirms compression.
When assessing power, gripping 2 fingers is a good screening tool. But to definitively pinpoint the integrity of the ulnar nerve, we use Froment's sign, the paper test.
This is a beautiful piece of clinical biomechanics that tests compensatory function.
Explain that.
The adductor pollicis muscle, supplied entirely by the ulnar nerve, is responsible for holding a piece of paper gripped between the thumb and index finger. If the ulnar nerve is weak, the patient cannot perform pure adduction.
So they substitute.
To prevent the paper from being pulled away, they compensate by recruiting the median nerve innervated flexor pollicis longus.
And the positive sign is that compensation.
The positive sign is the compensatory flexion of the thumb's interphalangeal joint. They are substituting adduction with flexion. It tells you the ulnar nerve function is failing, but the median nerve function is intact, allowing the compensation.
We also check individual tendon integrity. The superficialis tendon test is a great way to isolate the flexor digitorum superficialis.
Right, you have to immobilize all fingers except the one being examined in extension. If the patient can still flex the isolated finger, the superficialis tendon is intact.
And the OK sign.
The OK sign, bringing the thumb and index tips together to form a perfect circle, tests the anterior interosseous nerve, a branch of the median nerve. If the nerve is damaged, they can't form that perfect circle.
Shifting briefly up to the elbow, we first look at alignment, the physiological carrying angle.
Or cubitus valgus. The normal angle is about 914 degrees, typically greater in women.
And pathology creates angular deformities.
Cubitus varus, where the angle is reversed and the arm looks like a gun stock, is the classic outcome of a malunited supracondylar fracture in a child.
Movement assessment is straightforward. And the special tests here focus purely on inflammation at the bony origins.
Enthesopathy. Golfer's elbow, medial epicondylitis, is tenderness over the medial epicondyle, where the flexors originate. Pain is reproduced by resisted wrist flexion.
And tennis elbow is the opposite.
Tennis elbow, lateral epicondylitis, is tenderness just distal to the lateral epicondyle, where the extensors originate. Pain is reproduced by resisted wrist extension. The location and the resisted movement tell you the whole story.
So key takeaway 4 for the upper limb. The hand is a miniature nervous system evaluation.
Tunels and Phelan's screen for compression, Allen's screens vascular supply, and Froment's screens the critical ulnar innervated adductor pollicis muscle by observing the compensating function of the median nerve.
Okay, we're going to finalize our deep dive with the lower limb, starting with the hip.
Hip pain is notoriously deceptive. Pain felt in the groin or thigh can be referred from the spine, the abdomen, or the pelvis. A careful, systematic examination is mandatory.
During inspection, we look for alignment issues, particularly a fixed adduction deformity. The book explains that this makes the leg appear short. Why does that happen?
It's a classic example of biomechanical compensation. If the hip is stuck in adduction, tucked inward, the body has to tilt the entire pelvis upwards on that side to try and level the legs.
So the pelvic tilt creates a functional misalignment.
Exactly. It makes the leg appear short, even if the bone length is normal. This has to be distinguished from true shortening.
Palpation focuses on bony landmarks. Tenderness over the greater trochanter often suggests trochanteric bursitis.
Or an enthesopathy, yes.
Yeah.
Now, assessing hip movement requires that critical distinction between true and apparent movement.
So how do you assess true hip movement?
You have to prevent the pelvis from moving. The anchor technique is to place a finger or hand firmly on the contralateral anterior superior iliac spine, ASIS. Movement stops when that ASIS starts to move. That ensures you are isolating motion to the hip joint itself.
The definitive test for a fixed flexion deformity in the hip is the modified Thomas's test.
This is the most comfortable and accurate way to measure fixed flexion, which is a hallmark of severe hip joint disease.
Walk us through the procedure.
The patient lies supine and first flexes their spine and hips fully, rolling into a ball to eliminate any lumbar lordosis. They then hold the good knee to fix the pelvis firmly. Then the other leg is extended down.
And if the thigh cannot lie flat.
If it remains lifted, that angle indicates the fixed flexion deformity in that hip.
We test dynamic stability using the Trendelenburg test.
This tests the integrity and strength of the primary stabilizing muscles of the hip. The gluteus medius and minimus, the main abductors on the stance leg.
And the procedure is to have the patient stand on one leg.
Yes. A positive Trendelenburg test is when the pelvis drops on the unsupported side. The logic is crucial. The abductors on the standing side have to contract powerfully to prevent the pelvis from dropping. If they fail, the pelvis drops.
This test ties directly to leg length discrepancy, LLD.
Yeah.
We have to distinguish between real and apparent LLD.
Real LLD is an actual difference in bone length and is measured from the ASIS to the medial malleolus. Apparent LLD is caused by a deformity or a fixed pelvic tilt, which makes the leg appear short. This is measured from a midline anchor, like the xiphisternum, to the medial malleolus.
Let's use a case to solidify the Trendelenburg concept. Case study 3, the accountant with a wobble. An accountant, 70, presents with a limp. When he stands on his left leg, his right pelvis drops significantly. So the question for the listener is, based on the Trendelenburg principle, which side has the weak abductors? And why is this so counterintuitive?
The weak abductors are on the standing leg, the left side. And it is counterintuitive because the visible effect is the pelvis dropping on the opposite, unsupported side, the right side. The gluteus medius on the left side failed to stabilize the pelvis.
Moving to the knee hinge joint, defined by the extensor mechanism and supported by critical ligaments.
Inspection includes assessing overall alignment, varus, bow-legged, or valdis, knock-knee deformity.
For palpation, specifically detecting effusions, the technique has to be tailored to the amount of fluid. For large effusions,
We use the patellar tap test. You firmly push down on the patella, and if there's significant fluid, you feel the patella tap against the trochlea groove.
For smaller, more subtle effusions, we need a different approach.
That's the fluid displacement or stroke test. You stroke the medial side of the knee up into the suprapatellar pouch and then cross-fill the opposite gutter. You watch for a wave of fluid returning to the lateral side, confirming a small effusion.
Movement assessment includes the lag test, which addresses the integrity of the extensor mechanism.
A lag test assesses the dynamic function of the whole quad unit. The patient lifts the straight leg 10 degrees. If they're then unable to actively re-straighten the knee after you bend it slightly, that positive lag indicates significant weakness or a rupture of the quadriceps or patellar tendon.
The ultimate knee assessment revolves around ligamentous integrity. This relies on specific positioning.
And the absolute anchor here is that collateral ligament stress testing, MCL and LCL, must be done at 30-degree flexion.
Why is that angle so critical?
30 degrees of flexion relaxes the posterior capsule and the secondary stabilizers. This allows the examiner to isolate the primary constraint provided by the collateral ligaments themselves.
So we test the MCL with a valgus stress and the LCL with a varus stress.
Correct. But if we find instability even at 0-degree flexion, at full extension, that is a severe finding. It suggests injury to deeper structures, potentially the PCL or the posterior capsule.
And for the anterior cruciate ligament, the ACL, the most sensitive clinical test is the Lachman test.
The Lachman test is crucial. The knee is flexed shallowly, about 15-30 degrees, and the examiner gently pulls the proximal tibia forward. A positive test is excessive anterior laxity coupled with a specific finding.
The endpoint.
A soft or no endpoint. The quality of that endpoint, the subtle difference between a firm mechanical stop and a mushy lack of resistance, is the single most important diagnostic element in detecting an ACL injury.
Finally, the posterior cruciate ligament, the PCO.
The PCL must be assessed by looking first for a posterior sag with the knees flexed to 90 degrees. Then the posterior draw test is performed. You push the proximal tibia posteriorly. If there's more than 10 millimeters of posterior translation compared to the other side, it indicates a PCL injury.
Okay, so key takeaway 5 for the lower limb. Hip stability is tested dynamically with Trendelenburg.
Knee stability relies on the quality of the endpoint, especially in the Lachman test. And remember the crucial rule of checking collateral integrity at 30 degrees of flexion to isolate the ligaments.
We have completed a pretty comprehensive, high-yield deep dive into the fundamentals of MSK assessment from Baily and Love, Chapter 35. This framework gives you that necessary structure.
Let's just review those high-yield anchors one last time. We used the 3 W's to structure the history.
We relied on Apley's Trinity look, feel, move for the entire physical exam.
We used the plumb line for spinal alignment and noted that the contralateral straight leg raise is highly specific for an alarming central disc prolapse.
We used Froment's sign to catch that subtle ulnar nerve compensation.
And we identified abductor weakness using the Trendelenburg test. The pelvis drops on the opposite unsupported side.
This systematic approach ensures that you avoid missing the urgent or the rare problem hiding beneath the common symptom.
Exactly. Clinical examination is not just about isolated facts. It is about rapid pattern recognition and connecting anatomical knowledge to functional deficits.
If we connect this to the bigger picture, you have to remember that these special tests like the Lachman, Sperling's, or Lessegs are direct, organized probes into specific anatomical structures.
Ligaments, nerve roots, and tendons. Use this conceptual structure, but please continue to engage with the full text of Baily and Love to master every nuance and every detail.
So what does this all mean? Throughout this discussion, we focused on fixed pathology arthritis, tendon ruptures, disc prolapse. But remember how we briefly mentioned assessing for hypermobility, the Baton score, that 9-point score that measures joint laxity?
Right, like bending the little finger back beyond 90 degrees.
Exactly. So what are the long-term functional implications for a young patient who scores a 9 out of 9 on the Baton scale? How might that fundamentally change your surgical plan, your physiotherapy goals, and the patient's long-term stability prognosis compared to treating a fixed, stiff arthritic joint?
That inherent instability versus fixed stiffness presents a profound difference in biomechanical prognosis.
Now, that is something for you to mull over and explore on your own.